Hit record. Okay, hi. Welcome everybody to our 20th edition of POCUS VMR, which we started about 3 years ago. I think Sanjay, you brought the first case, I think, to POCUS VMR. So Sanjay Patel has been helping us for many years in recruiting people to present cases on POCUS VMR and also teaching us POCUS on clinical problem solvers. So before we get underway, I'd like to just ask Dr. Patel to unmute and introduce himself and just tell us a little bit about POCUS education.
Yeah, thank you, Ravi and Deborah. I appreciate you both inviting us POCUS colleagues, to come and present a case and walk through some ultrasound education and integrate that into clinical reasoning. I know, like you said, I was texting you last night and didn't realize this is the 20th one that CPS has done, but I just wanted to thank you all on behalf of like the SHM point of care ultrasound SIG to have us here, and hopefully can recruit some other of our folks to present some more cases over the course of time. And I see some of our exec members, including Steph and Christian, who are presenting, but Linda, Mike, I think I saw Maggie on here as well. So appreciate you allowing us from SHM to present some cases for you. So I will hand it back over to you guys.
Oh, absolutely wonderful. I appreciate SHM, proud member of this organization as well. And we have both of our guests today, Dr. Stephanie Connor and Dr. Chris Bain. So I'll ask Dr. Stephanie Connor to unmute and introduce herself, and then Dr. Spain.
Sure. Hi, everyone. I'm Stephanie Connor. I am an academic hospitalist and the medical director for the hospitalist group at Columbia University Medical Center in New York. I've been doing POCUS for pretty much my whole career now, maybe since like 2016, 2017 or so, and then have been involved with the SHM SIG for also many years, though I'm not sure exactly how many, but very happy to be here with everyone.
Yeah, so I'm Chris in España. I started the point of care ultrasound program at Danbury Hospital. We started in 2016. That program started to grow, and now it's managed by my students and residents. Recently I left Danbury Hospital, and now I just started the point of care ultrasound for the Centers for the Greater Community in Connecticut in Danbury. It's a internal medicine residency that also goes to Danbury Hospital and Griffin. And I'm helping Griffin to put their program together. I also have my own course in my that I'm trying to put together, and yeah, that's what it is. And I love to be here. I love to be here.
Awesome. Yeah, we really love having you here as well. Excited for your case as well. So I'll introduce a few other vital CPS members without whom we also couldn't do this. So Eugene is co-discussing today, and Eugene is zooming in from abroad. You want to introduce yourself as well?
Yeah, hello everybody. My name is Eugene Bonzi. I'm a medical officer here in Ghana and a proud CP Solvers member. Not too much experience in POCUS, but then I'm excited to be discussing today.
Awesome. And then we have Mohammed, who's helping us with scribing duties today. How are you, Mohammed?
Hello, everyone. I'm Mohammed, a medical graduate from Iraq, and I'm really excited for POCUS.
Awesome. And last we have Sakith. How are you?
Hello, everyone. I'm Sakith. I'm a graduate from India. Excited for the case.
Awesome. Can you believe how much of an international community we have that are helping with this endeavor as well? So I'll hand the mic over to Chris and Stephanie to start with the case, and Eugene, you'll take first stab at the first aliquot.
Great. Thank you. So, I'm going to present a case from when I was recently on the step-down unit in the hospital in December. The case is of a 77-year-old man with a past medical history of dementia living in a nursing home who came to the hospital initially with cough and shortness of breath, But then our team was called during a rapid response 3 days into his hospitalization with acute worsening hypoxia, new hypotension, and new A-fib with RVR. Do you want me to
Okay.
pause it? Yeah.
Yeah, that's a fantastic opening. So we have a 77-year-old who seems to have an infectious prodrome, cough, and then shortness of breath, and possibly acute or subacute, and then in a deteriorating state. So, I mean, first thought process, a demented patient having cough, shortness of breath, I'll think about pneumonia as the possible cause, or even aspiration pneumonia. So if this patient had a problem with swallowing, he could have aspiration pneumonitis. And so that could be the initial presentation. And then why is this patient not having acute hypotension and then deteriorating so quickly? Things that would trigger my brain immediately with a patient that is rapidly deteriorating and probably would need a rapid response. We could think about pulmonary embolism, because that could cause the hypotension and then also cause possible tachycardia. So that will be another thing that I'll be thinking about. And then we will not just let it lie there. We also have to think about all the possible causes of dyspnea in a 77-year-old, because he's already vulnerable. There could be some underlying cardiomyopathy, valvulopathies that are now in acute exacerbation. So the patient may be just deteriorating. We can also think about maybe just a possible but we could have metabolic causes as well. So if this patient, I would want to know the past medical history. So if there's a diabetes component, a DKA could trigger this patient to have this acute shortness of breath, and then also hypertension. So I'm just thinking around this area. Or could it be his medications? There could be a constellation of medications that he's taking that have caused the hypertension. So those are things that I'm thinking around and would seek more data. Then I'll pass the mic on to Dr. Ravi.
Absolutely wonderful start, Eugene. Utilizing what you know and trying to figure out what has happened with this patient. So the narrative here is this patient is gravely ill, and the initial cough, shortness of breath has culminated in this rapid response. So there's something where this patient is, the patient's trajectory has led to this decline. And I look at, A-fib was interesting. A-fib with RVR, it actually can cause hypertension if you have a diseased heart, like you mentioned, cardiomyopathy. But what I'm thinking is A-fib may be secondary to sort of like a fever of the heart. It's going out of control because of something that's throwing the heart off its equilibrium. I'm really interested in the lungs. If I'm trying to think of a system right now rather than diagnosis, the lung is at the center of gravity. Hypoxemia, the patient isn't able to maintain oxygen saturation, and then the heart suffers, and the A-fib is spiraling out of control. And because left ventricular filling may be compromised due to rapid ventricular rate, hypotension may result in this case. So the lungs need to be evaluated. And also, we know this is POCUS VMR, so we need to have imaging. Even if we get radiological imaging, we get lab studies as well. All of that will help us with making the diagnosis. But we kind of have to think on two planes here. One plane is what's going on. Second is stabilizing the patient. But I'll send the mic back over to Stephanie for the next dialogue.
Great, thank you. Just there was a comment in the chat about potentially sharing the whiteboard so that people could follow along with that.
Sure, we could do that, yeah.
Yeah, okay, great. So yeah, really, really great context for all of this. So just to provide a little bit more background to the kind of days leading up to this, Eugene, you mentioned his past medical history. So his only medical problem that we are aware of is dementia. He doesn't have diabetes, hypertension, no cardiac disease previously. He is pretty debilitated from his dementia. So he lives in a nursing home. He's completely dependent in all his ADLs and IADLs. And his family and the staff at the nursing home really note this kind of, subacute decline where they had noticed recently some coughing with eating. So I think potentially your thought around aspiration pneumonia is a very good one. On admission, he had required 3 liters nasal cannula, which was new for him. He had never had an oxygen requirement before. But otherwise, he had normal vital signs, including normal blood pressure, normal heart rate, and they had an ECG from admission that was normal sinus rhythm. So again, their A-fib is not a known problem for him. Looking back on the admission exam, they had noted coarse, quote unquote, coarse breath sounds bilaterally, no edema. They commented that his heart was regular rate and rhythm. And at the time that he was oriented to himself only, and that he was fairly lethargic. Other notable things just for context. So on admission, he had a mild leukocytosis. So his white count was 12.5. He also had a chest x-ray done at the time that showed a bilateral lower lobe consolidations consistent with pneumonia. They had checked, troponins along with the ECG. Those were negative. There was a BNP, which my institution uses a lot as kind of a rule out for heart failure. That was negative. And so when he was admitted to just the med-surg floor. He was started on your typical kind of IV antibiotics for community-acquired pneumonia, the supplemental oxygen, and they had planned to further investigate or do further diagnostics to investigate more of the aspiration concern. Also of note at this point, in the earlier discussions with the family and healthcare proxy, they had limited his goals of care to DNR, DNI with, no invasive interventions, just kind of give him what his baseline mental status is. So leading up immediately before the event, his oxygen requirement had been stable but persistent in the 3 to 4 liter range, but he had remained afebrile with stable vital signs otherwise. They actually had done a CT chest non-con the day before, which confirmed the bilateral lower lobe pneumonia, worse on the right, as well as a small parenchymal abscess associated with the right lower lobe infiltrate. And then overnight, right at change of shift, the rapid response was called because newly his blood pressure was 87/55. His hypoxia worsened to the point where they had put him on a 8 liter face mask, and his had developed A-fib with RVR with rates in the 130s, which was new. Prior to us arriving, he was given a liter of IV fluids, and we were called to evaluate him.
Absolutely. Wonderful detail there, Stephanie. This is a patient that I also see as a hospitalist. We see it many times. These are one of the most difficult kinds of patients that come in and exhibit some sort of stability and then decompensate in the hospital. And I think developing sepsis, septic shock in the hospital is one of the most easily unidentified patients because of the lag that you get on the floor. Maybe lack of access to frequent vital signs or rounding on the patient and so on. Whereas in a ICU step down or ICU, these patients are monitored minute by minute. So very disheartened to hear this decompensation in the hospital, but it's probably originating from what the patient came in with. If we go back to the initial aliquot, so this patient is having cough with eating, and the initial hypothesis was something in the lung, maybe aspiration. Oxygen requirements have gone up, so VQ mismatch is happening. Probably the most common cause of hypoxemia in patients. And then the exam does support this hypothesis by listening to the lungs. We're seeing or hearing coarse breath sounds bilaterally. The other hypothesis could be AFib with RVR and decompensated heart failure, but we're not seeing anything like JVP, peripheral edema. You had mentioned no edema on the extremities, and also the BNP not being elevated. So we can sort of put that on the back burner and still roll with the pneumonia as a possible cause of this decompensation. The labs, now turning to the labs, we've gone through history, physical, now looking at the labs, the white count, 12.5. So it is somewhat elevated, but if we do a repeat white count in a few hours, it's probably surging with this sepsis picture we have. And then this low blood pressure no fluids are given yet, but if fluids are given, usually the 30 cc's per kg for somebody who is having sepsis, if there's no response and continued hypotension, then we establish that this is possibly septic shock during this rapid response episode. So at this point, I think the lungs again are the center of gravity. And the CT chest is interesting. This intraparenchymal abscess on the right, which is showing a focus of infection. Like it takes days to develop an abscess. I'll turn the mic over to Eugene for any thoughts about abscesses in the lungs, and what are your thoughts regarding this?
Yeah, absolutely. So I think you've laid down the foundation for this second aliquot, which is, I mean, we have a patient who had an infection which is getting worse. And so we're thinking about sepsis at this point. And if not responding to fluids, we're thinking about septic shock. And when you pick sepsis, the first point is you want to actually deal with the source. Source control is what would actually alleviate the patient from what they are experiencing. So looking at the abscesses, it means that the kind of bag that we're dealing with here is possibly a very notorious bag, and that is why this patient is having these abscesses in the lung. So our typical, Staph aureus can do that, a strep pneumo can do that, coupled with the fact that this patient is an older patient and probably in immunosenescence, they could actually be really hit by this particular bag. Or could it be that there is some compounding nosocomial infection from the hospital that is also adding up to this? Or could it be from the gut? Because you already talked about aspiration pneumonia. Some of these gut bacteria can actually, they are, anaerobic. They can actually lead to this kind of empyemous abscesses in the chest area. So I think this being a POCUS VMR, I'm sure we're thinking already of putting a probe to the chest, but we already have a chest CT, so I don't know where that will play. And like I said, I don't really have much experience when it comes to POCUS, so I'll leave this to the experts to decide at this point. But to also add a little bit, I think just to explain the orientation, I think the severe sepsis will lead to catecholamine surge, so that's why this patient is possibly altered in mentation. And then I'm also thinking maybe there's a component of pulmonary edema. Maybe the alveolus are wet, and that is why this patient needs so much oxygenation. Because in my experience, I'm not seeing just consolidation needing so much oxygen to sustain a patient. So just another thought that I'm throwing in out there.
Yeah. Perfect.
That's a
Yeah,
good
this
one.
is exactly what we were discussing as the team was headed to go see him. And, I think one of the things that's really interesting that you mentioned is we talked about what is the relevance of this CT that was done just the day before, and how does that impact our decision making now? And then the other thing I really like that you mentioned is obviously we're all concerned and thinking, is this uncontrolled sepsis? But at the same time, he's not spiking a fever. Yes, he has tachycardia and he does have hypotension, but the white blood cell count from admission had been stable, if not improving. So there were a couple of things that didn't totally go along with that. And so the other thing you brought up that's a really good point is, can you get some sort of cardiogenic edema? Is maybe that now playing a role, and so this is where I think potentially, our POCUS can help us. And then actually just to address in the chat what antibiotics they were on. At that point, he had been brought into Zosyn already. So he was started on ceftriaxone azithro on admission. He was not given Vanc because his initial MRSA swab was negative. So I think he got like one dose of Vanc in the ED and then it wasn't continued. And then that was brought into Zosyn when he was not clinically improving on like day 3 or so. And then also in the chat, the procalcitonin just came in. So procal on admission was negative 0.07, and at the time of the rapid was still negative at 0.17.
No, so it was negative, huh?
Yeah.
Procal.
Yeah.
Okay, interesting.
Yeah.
Yeah.
Okay. So I think next, right, we were talking a little bit about this, and just to share what some of the team's thoughts were. We thought at this point, we were worried a little bit about PE as well, though notably he had been on appropriate DVT prophylaxis and receiving it for the duration of his hospitalization. We thought he was a little too acute to move to the scanner. And again, because of the DVT prophylaxis, we thought maybe not as high yield. And so, we had done an exam which was largely stable from what they documented on admission. But I think one of the things we really noted, and this is where me as a POCUS person really wanted to kind of pivot to POCUS, is that especially in these rapid response scenarios, your exam is fairly limited. It's loud, there's a lot of people in the room. His mental status isn't great, so he's not taking deep breaths when you ask him to, and so it's like you're taking a physical exam that, we'll talk a little bit about this later, but doesn't have perfect test characteristics at baseline. And then you're applying it to a very acute setting where your test characteristics are worse because they're not able to really participate in the exam in the way that you would want. And so this is where I think, really turning to POCUS can be helpful here. And so that's what we did. Christian, I don't know if you want to
absolutely. I will try to share. Allow multiple, allow, and this one. You should see case videos, if I'm not wrong.
Yeah, we see it. Yeah.
Beautiful. So case videos. So give me 1 second. Okay, beautiful. This is our first image from the case from Dr. Connor. And basically this is a 5-chamber view. If you can see, I don't know if you're can you see my arrow?
Yes, we see it.
Perfect. So basically it's a 5-chamber view mostly. Sometimes it becomes 2, but most of the time it behaves like a 5-chamber. So here we have the apex. This is a beautiful view. We have an endomyocardium of this patient. We can see that there is most likely a decrease of the ejection fraction, since the endomyocardium does not thicken in the volume of this part, or the left ventricle does not decrease enough, despite the good the good movement of the mitral and the anterior leaflet of the mitral valve. Now, this is interesting because this ultrasound is telling us a story. Below the mitral valve that we have here, we have the atria, the left atria. And you can see that the left atrium is larger than the ventricle, or at least appears larger than the ventricle. These are the pulmonary veins, by the way. So this is telling us that this patient has had for a long time at least either a valvular problem or a myocardial problem that has created diastolic dysfunction, and that's why the atria is so enlarged. And most likely, this is how the patient ended up having atrial fibrillation. You can see that the rhythm is not normal. In the right side, we have a right ventricle. We cannot see much more about this right ventricle. This is the problem with POCUS. We need to deal with what we can. And we see a very large right atria and a tricuspid valve here. Probably the posterior tricuspid valve, it's going up and down 2 centimeters, which maybe that tells us that the right ventricle is not failing. But overall, this is a heart that is failing, and a heart that has maybe a decreased ejection fraction, not in the 30s, but certainly between the 40s to 50s, and of course enlarged atria. In the valves, at least, there are no gross abnormalities that we can see, although we do not have Doppler for that. So anyone wants to?
Yeah, Chris, one question. That septum looks like it's bowing to the right ventricle. Is that correct?
Well, the septum, I would say the movement of the septum is just a septum of someone who who has some sort of cardiomyopathy. Probably this patient has mostly ischemic cardiomyopathy. I will bet on that. I don't really see the septum bowing abnormally. Now, if you think about it, this part of the septum has a little bit of decreased motion. So there are abnormal motion of the septum, but more than kind of bowing. I would not bank on that.
Yeah, I think what you're getting at is like McConnell's sign, right? I
Yeah,
would not call this.
that would
I
not.
wouldn't call this McConnell's sign.
Yeah.
I think to Chris's point, it seems like both because of operator, imperfection, but as well as just he probably has some long-standing ischemic or other cardiomyopathy of his heart. And so it's just that area is a little more visible than other areas in the left ventricle.
Yeah. Well, we have any other question? We can go to the next one.
Yes, we can go to the next one.
Yeah, so this is the IVC of this patient. The IVC of this patient is taken in a long axis with a phase array probe, and you can see here that the hepatic vein outlet is visible. So probably it's a good IVC. So it's probably in the axis is good, and you can see how despite that there is some inspiratory collapse, it's not more than 50%. And also, if we were to measure this, it's probably already more than 2 centimeters. So this is telling us the story of a patient who probably is already congested in the case of our patient that we are talking about. So where you would like to measure this again is right before the, depends on who you're reading, right? But right before the hepatic vein, the main hepatic vein here, right here. And I would say this is a blunted response to respirophasic response.
Yeah. The only thing I would add here is that the IVC we kind of thought of in two different ways in this particular case. One is kind of diagnostically, like Chris is talking about, to say, is this patient already congested? Is that maybe what's leading to the acute hypoxia? But the other is because he's hypotensive and has AFib with RVR, the other question is, should we give him more fluids and do we think that'll help? And in the literature for IVC POCUS, those two questions actually have different answers in terms of what your cutoffs are. And so while, the characteristics would say, yes, he is, congested and that's potentially contributing to his hypoxia. The other thing that was very useful about this is that because the IVC is so dilated, I think when we measured it, it was like 2.7 or something like that. It actually was above the cutoff for where you would say, where the literature would say the likelihood that he is fluid responsive is very, very low. And so those are actually, just to call it out, they're slightly different questions, but both pieces of information you can get from here.
So at this moment, I think we have a very interesting part, which is the decision making. Like that's I think one of the fantastic things. Right now, we are thinking maybe this patient is not going to benefit from fluids despite the vital signs, and then we have the lungs. That's also Dr. Sconner patient, and you can see. In this case, you can see the pleura right here, and this is taken with a GE venue, and it's a phased array probe, and you can see here the pleura, and you can see multiple lines that have erased all A lines. The multiple B lines are dynamic. They are long as the field of view is. And they move with the pleura, and these are classic from pleural effusion, not pleural effusion, I'm sorry, pulmonary edema. Oh my God, I'm sorry, pulmonary edema. So That means, and if everything is right, the presence of pulmonary edema tells us the story in this specific patient that he probably is already overloaded, and the benefit from any type of IV fluids on top of having the IVC that we just saw, having the heart failure that we just saw, that probably will be detrimental for the patient, and we need to look for other avenues. And I think that's how our decision making should be should be guided in this case.
Perfect.
Yeah,
Yeah, it's hard to see because this is only one representative image, but the important thing about these B lines is that they were diffuse and bilateral, right? Because
correct.
we do know that he has pneumonia, and pneumonia can look a lot of different ways on POCUS or on ultrasound, but one of the things it can also do is B lines. So that's where it's
Yeah.
sometimes confusing. And so the fact, though, that this is diffuse, that it's bilateral, that it had some kind of worsening in the dependent lung zones. And then there's one other finding that I think Chris is about to show us, that makes it more consistent with it being a cardiogenic pulmonary edema rather than the pneumonia itself. I'm sure if we had looked at him a few days prior, especially in the lower lung zones, he probably already had some B lines or maybe a more organized consolidation because of the pneumonia. But this is kind of now we're thinking a separate process.
Yeah, so when I'm rounding, sometimes I tell the patients, let's go and count V lines when we're diuresing patients. And it's interesting because the V lines actually do disappear. And we count less and less, you know. Here, that's the next slide. And in this case, we have well, we could call it a area 8, or no, I mean, area 4 of the right, of the right, yeah, it seems to be the right. The right lower lobe, and what we see here, it's the diaphragm. It's a bit obscure here, but again, you can see it here, and you can see fluid. You can see fluid above the diaphragm. So this is diagnostic of a pleural effusion. I don't have enough to say what will be the size of this pleural effusion. However, the pleural effusion is there. Right pleural effusions are usually associated to hemodynamic problems rather than the left pleural effusions that we will see most likely because of inflammation or other things, although that is not 100%. You can see also the Morrison's pouch. The Morrison's pouch is at least what we're seeing dry, and the spine here. So yeah, so now we have a little bit more of the story, right? These images are telling us a story, and telling us a story of a left ventricular failure. It's telling us a story of very large atria, and the large atria maybe are telling us a story of a very bad diastolic dysfunction. The movement is telling us about probably ischemic cardiac disease, an increased size of IJVD, I'm sorry, IJ, and then the pulmonary edema, and now we have the fluid outside the lung, and then we most likely are dealing with a very congested patient.
Remarkable pictures there. Stephanie, I just want to ask, at this juncture, when you did the POCUS, was the patient in rapid ventricular rate with the A-fib?
He was still, yes, he wasn't as high as he had been, I believe, but yeah, he was still like 120s. Yeah.
Okay, so yeah, this completely changes the landscape and has done a 360 with this case. Initially, what was the narrative kind of was building, I was sure this was heading towards sepsis and septic shock, and he got the fluid. We do that. I see that in a lot of rapid responses, that fluid just is given. It's a reflex for hypertension, but just taking a time out and then looking at the patient with the ultrasound, it sheds light on what is going on. What's interesting, the ProCal, I've had some issues with it. Sometimes it misses bacterial infection, but here it helps because it was normal. And then the ProBNP was markedly elevated as well. Maybe he hasn't had time to really kick that up to a significant level. So in this case, what I would start thinking is if the A-fib is compounding this, sometimes controlling ventricular rate in this case can help reduce the congestion that's building up. And then with this low blood pressure, sometimes the heart rate is really high. If the blood pressure is low, you can actually defibrillate the patient. And once they achieve normal sinus rhythm, maybe they become normotensive enough to diurese the patient. And like Chris had mentioned, we see that too. When you have the bilateral B lines, you decongest the patient, and you see those B lines become A lines right in front of your eyes as well.
Yeah, absolutely. Yeah, that was, I think we were very much in a similar boat. And I think the one other thing I'd add, right, is that we were all, I think, very nervous with his respiratory status, especially knowing that he had limited goals of care. And so I think these were pretty surprising to us to see kind of how congested he had gotten, over a relatively short period of time. And then again, having the CT non-con from the day before where there was no pleural effusion. And, honestly, this is a small pleural effusion. It's not driving his significant hypoxia, though, certainly not helping. But just to see that, as of 18 hours before, he had these kind of consolidations, but no comment on, or no pulmonary vascular congestion that was seen, and no pleural effusions. And CT really is your gold standard for pleural effusions. It was very impressive to see the change.
Yes. So this is quite a common issue that we take care figuring out if what is the patient needs is rate control, or the patient needs pressors, or the patient needs something else. In this case, it seems that rate control could actually be the answer. So we have like a better flow and of course better pressures, and then of course a chance to improve the respiratory status of the patient thanks to diuresis.
Yeah. Just to address the comment about the pneumothorax in the chat, Christian, do you mind going back to the other lung image real quick? So the pleura moving that Eugene's referring to is up at the very top here. I don't think you can see my marker, but Christian, if you want to just show him the pleural line.
Yeah,
And
absolutely.
yeah. So what you're looking for is basically, do you see kind of like a twinkling or movement with respiratory motion? And the fact that you can see B lines underneath actually kind of excludes pneumothorax in that area. Because for
Right.
a pneumothorax, there has to be air separating the visceral and the parietal pleura, and air
Correct.
kills your ultrasound. So you wouldn't be able to see anything deep to it if there was air separating your visceral and parietal pleura. So the fact that it's sliding and moving and that there's B lines underneath, both of those speak against the pneumothorax.
Yeah, it's beautiful. Just want to show one thing. This is a patient who has atrial fibrillation, and you can see that. Well, I mean, this patient is sick too, but you can see that the rhythm is normal, and sometimes there will be an opening of the mitral valve that is larger than the other openings. So that needs to be controlled. And then I just want to show this one. This is an IVC that from a patient who had significant right ventricular failure along with left ventricular failure. And one of the surrogates that you can see for chronic congestion, because at some point your IVC will become ectatic, and sometimes the IVC may not go 50%, have 50% of collapsibility. If you see right in here, this is the hepatic vein. Either base of the hepatic vein or where the hepatic vein enters is more than 0.9 centimeters, then you may want to say that this is congestion. And yesterday, Sanjay wanted to, this is a normal IVC for everyone. There's a happy, beautiful IVC. And you can see how it just contracts, and this is a patient, this is probably me, and it all depends on what you find and what you are going to do with the patient. And Sanjay was asking me if we had any internal jugular evaluation, and I found this one. This is a patient who definitely was volume overload, pulmonary edema, and everything, but you can see right here the carotid and some plaque. And this is the IJ of the patient. The IJ should basically almost disappear in inspiration at 35 degrees, but have at least 30% of, more than 30% of collapsibility, which this patient was not having. In fact, every time you see that the IJ increases is when the patient is having a deep breath. And that's what I have. I'm going to stop sharing so we can talk.
Yeah, absolutely wonderful. I really appreciate the teaching of the cases. I guess the images of the POCUS, and again, it markedly changes the approach to this patient. So I want to ask Stephanie, what was the outcome like? What did you do for the patient and the resolution? And it's interesting, like with the goals of care being limited, and like a lot of times you say this 77-year-old patient with a baseline of dementia, sometimes that can cloud your approach to a patient too. But I think it's always you can always give it a fair shot, try and stabilize within certain limits, and get the patient to equilibrium if possible. But what did you do in this case, and what was the outcome then?
Yeah, great. So yeah, so taking all of that into consideration, we as a group were very hesitant, as you'd imagine, to give him any more fluids. And so we did start an amiodarone drip to try to control his rate better and potentially convert into back to sinus rhythm. And that did help. That brought down his heart rates to maybe like 100 or so. And with that, his blood pressure did improve slightly. He was previously normal, like 120s or so. With the amiodarone drip, he improved into like the mid 90s for systolic blood pressure, but I think adequate for perfusion. And his mental status improved slightly with that too, which is another kind of bedside assessment for perfusion. His respiratory status had stabilized, though at a higher level. He was now at 6 liters or so. And I think the big discussion that we were having ultimately in terms of etiology was, is this that, as we saw with his heart, that he's a man who's having progressive kind of deterioration of his heart, and now he's just kind of tipped over the edge and now is starting to have sequelae of that, right? So new A-fib and those kinds of things. Or did he kind of flip into A-fib with RVR because of the underlying infectious process and then develop flash pulmonary edema? That was another consideration. And I think the other one too was, is he just continuously aspirating? And he was NPO, but he was having some secretions, and just aspirating on your secretions can also cause a similar picture. And so with all of that, we stabilized him, and then we spoke to his family some more. This is actually another kind of, I think, like a little bit of a cheat code with POCUS. And actually, I think Sanjay just published a paper on this. People really understand what they can see. And one of the things that we did in this case, because the family kind of kept saying, if not for the dementia, he's otherwise very healthy. He's very healthy. He's very healthy. And I think one of the things that we were able to kind of help them understand is that might be changing, that some element of his cardiac dysfunction could be acute from the acute setting that he's in, but that he has these longer term signs as well of kind of progressive deterioration. And so being able to kind of show them the images, describe, what this looks like going forward in terms of the additional testing and things like that, they actually decided at that point to transition his goals more to comfort care. Even though we had kind of stabilized him, though albeit at a worsened kind of state than he was at before. So we transitioned him to comfort care ultimately, and he did pass away in the hospital with his family at bedside and appearing very comfortable.
Wow. Remarkable case, remarkable images, and teaching, and remarkable outcome and compassionate care for the patient. Well, I really appreciate both of you bringing this case. And I think what we can really take away from this is that these images give a window into how ill the patient was. Like you said, I was like, with the first aliquot that there's a patient with dementia, we see quite a few patients, but nobody knew about how really sick he was internally with the heart. And by informing the patient's family of this, I think they could understand or come to terms with why how sick he was from the get-go. We do see a lot of A-fib nowadays, A-fib developing in the hospital due to infection, right? So anybody with sepsis has a tendency, especially with Chris showing that dilated left atrium has a very high likelihood of turning into atrial fibrillation or potentiating atrial fibrillation. So we do deal with this scenario here. You know, the other kind of case combination that I do deal with is a lot of like patient coming in with COPD background and having heart failure. So which one is it, COPD or heart failure? Which one should you go with? And the same thing with this, sepsis and congestive heart failure with that AFib. And the other one I've had a patient where I used POCUS was a patient with sepsis. So initially identified as having sepsis was actually pulmonary embolism. So, and doing a POCUS in the emergency room can really help shed light on the underlying pathology. Really appreciate the high level teaching and the POCUS images that you brought today. Any reflections, Eugene, any reflections before we ask reflections from both Chris and Stephanie?
Yeah, absolutely amazing case. I think what I'm taking home from this case is that, you know, whenever you see your patient and then you think they're too sick, and what you are finding on maybe a CT scan or whatever imagings that you've done, it's not enough to explain. I mean, it's important to also go a step further to investigate. In this case, we use POCUS to check the heart, to check the chambers, and then got to know that the left atrium was dilated and possibly explaining the atrial fibrillation. So I'm happy that we didn't just stop at the advanced imaging that we had already, but we also went a step further and did the POCUS, which is a very great charge into. I've learned a lot from it from just this short discussion, and I think I've added to whatever that I knew about it, and can also say that, yeah, I've graduated from novice level to just a little bit up there with POCUS, yeah.
That's how POCUS works. It's incremental.
It's incremental. Yeah. Thank you. That's correct. That's correct.
All right, wonderful.
Well,
Chris, any final words?
I think this was a very, very nice exercise. I think we started with the patient with sepsis. At the end, we figure out the problem is more cardiac, and more than that, Dr. Connor was able to show the family in real time with the real images of the patient what is going on, which is something that I advocate for my residents and students to do. And I think that's part of having this amazing resource in our hospitals and clinics.
Yeah, I agree with that as well. And even a lot of rooms have computers in there, and you can also share or show images like CAT scans and X-rays to really help with families understanding what their loved ones are going through. Stephanie, any final reflections on your fantastic case?
Yeah, I think, for me, what I always come back to is the importance of the bedside assessment, whether that's your physical exam or point of care ultrasound. And when you think about it, for me, everything is a diagnostic test with test characteristics. And all we're trying to do is kind of bring the best test characteristics that we can to the bedside for appropriate diagnosis. So I think, for people who are using POCUS in their clinical practice, there is nothing better than longitudinal assessments. So the only thing that could have made this case better is if someone had POCUSed him on admission so that we knew kind of what the baseline was, potentially would have picked up some of the cardiac things a little bit sooner. But then also so that you can really appreciate the change. And it's very parallel to kind of your physical exam, and how when you see someone day after day, you're looking for, are those crackles less today? Are his legs less swollen? And that's essentially what we're doing here as well. So I think the biggest thing I would say is serial assessment. So if you're using this, use it serially, and then multi-system as well, right? I think where people get a little bit stuck is when they kind of live and die by one finding, right? So they just look at the IVC, or they just look, at the lungs or something like that, when really the data tells us that the best value for this is really in a multi-system exam. So I'd very much advocate it.
Correct. That needs to be stressed. Multi-system exam. Yeah.
Absolutely wonderful words. Yeah, I really appreciate again for you, the teaching that you've done today.
Thank
We'll
you.
wrap it up. Thank you, sir. And we'll wrap it up with Sakith telling us any teaching points from the case. Over to you, Sakith.
Yeah, thanks a lot for the amazing case. Dr. Schmidt and Dr. Connor already outlined the main teaching points. So I will just highlight some of the pearls that I sort of learned. We initially saw a patient who came in with a classic picture of a septic shock, and there are a lot of other signs that sort of anchored us initially towards an infectious etiology. But once we got the POCUS, we saw that he had more of a congestive picture, likely secondary to a cardiac dysfunction picture. With the echo that showed a decreased impaired contractility of the LV and the enlarged LA that likely also explained the A-fib that the patient presented with. And the IVC was also extremely dilated with a less than 50% collapse, and that's classically indicates a congestive picture. And then finally, we saw the lung ultrasound had multiple diffuse D lines, and that's also classically seen in patients with pulmonary edema. So yeah, in the end, I think the main teaching point was use POCUS serially and track progress in the ICU, and gather multiple data points with a multi-system exam to make decisions.
Well, thank you, everyone. I need to hop out. I have a lecture right now. Thank you.
Sorry.
It was fantastic.
One
Thank
lecture
you.
to another, Chris.
Yeah, we need to do another one. Yeah.
Yeah, maybe
Yeah,
we should join
anytime.
your
I
lecture
love
as
it.
well. Maybe you
Yeah.
should join your lecture as well. Then. All right. Thank you very much, everybody. That concludes today's session. I also want to appreciate Sanjay Patel for bringing us great faculty members to teach us today, and he's always been a champion of the collaboration of POCUS and CPS. Take care, everybody. Have a wonderful rest of your day. Bye.
Thanks,
Thank you.
everyone.
Thank you. Bye.